Hi, I'm Akshay Baheti, and welcome to the Cafe Roentgen Journal Watch, where we review certain important or interesting radiology articles. This time we are focusing on lung cancer screening. Most of you might be aware that actually the mortality by lung cancer now exceeds the mortality by breast, cervical, and colorectal cancers combined. Although obviously the incidence of lung cancer is less than that of the other three cancers combined. And perhaps one of the reasons for this is that screening does exist for the rest of the three cancers, whereas lung cancer screening is something which is recently discovered and talked about and not implemented as much per se. So what do we need for a good screening test? We need a test which should be reliable and valid. It should lead to a true improvement in survival, and the cost benefit ratio should make sense. Um, the largest study on lung cancer screening was by the National Lung Screening Trial from America, and this was published in NEJM in 2011. And we're going to talk a little bit on this. Um, so this included more than 53,000 smokers at risk, and they either received annual chest X-rays or annual low-dose CTs for 3 consecutive years. The trial clearly showed that there was a 20% reduction in lung cancer mortality and a 6.7% reduction in all-cause mortality in the CT group. Um, Unfortunately, there are a lot of false positives as well. So around one-fourth of the patients had some positive finding on CT, and 95% of the positive findings were false positives. Nevertheless, the significant decrease in mortality led the United States Preventive Services Task Force to issue this guideline that annual screening for lung cancer with low dose CT in adults aged 55 to 80 years who have a 30 pack year smoking history and currently smoke or who have quit smoking within the past 15 years is completely important and valid. But a lot of unanswered questions still exist. For example, can we screen patients with less than 30 pack year history? So this history is based on the inclusion criteria of the USPSTF trial. Can we screen younger patients again? Can we obviously decrease the false positive rates, which are pretty high? And can we perhaps increase the screening interval from 1 year to something longer? And this trial is probably something which has answered some of these major questions. So this was again a prospective randomized control trial by the Dutch and Belgian group published recently in NEJM. And this included around 15,700 patients, including around 2,500 women, who were randomized to either low dose CT or to no screening. These patients smoked greater than 15 cigarettes a day for 25 years or greater than 10 cigarettes a day for 30 years. So this would actually be around 15 pack year history or more. The screening CT were slightly different in order. So the patients underwent CTs at 0, 1, 3, and 5.5 years. So the screening interval kept increasing gradually. Instead of measuring diameters, as was done in the National Lung Cancer Screening Trial, this trial measured volume of the lung nodules as the follow-up regimen, and then the patients are followed up till 11 years of the first CT, and then the findings are published. How were the nodules classified? So a classic benign nodule was category 1. Any nodule which was neither category 1 nor 3 was considered category 2. These are usually non-specific nodules that we often see on CT. And both of these were considered negative studies for which routine follow-up was recommended. So no additional CT was needed to be performed. Category 3 was a number of things depending on whether it's solid or a part solid or non-solid nodule, but it was based on volume and a little bit on diameter. And importantly, these were considered indeterminate and a 3-month follow-up CT was performed for them. Category 4 was larger volume, and these were considered suspicious and a biopsy was needed for this. So what were the results? Uh, Over 22,000 CTs were performed. The mean age of patients was 58 years and the median pack was actually 38. So although the inclusion criteria included patients with more than 15 pack years, you can see most of the patients had a pretty high history of smoking. The adherence to the trial was great. More than 87% patients actually completed all the CTs. Um, Importantly, only around 20% patients had indeterminate lesions on baseline, and this decreased substantially in follow-up to around 2 to 7%, and is much, much better than what we saw in the earlier study. Uh, um, More importantly, only 2.1% of these positive CTs needed further workup. So most of the patients with indeterminate lesions did not need further workup. Only 2.1% needed further workup, and around 0.9% of them were true cancer. So the positive predictive value of a positive finding on CT is actually pretty high in the study, 43.5%. And there were no adverse events. Looking at the mortality, it was very clear that there was a substantial decrease in lung cancer mortality in the screening group. So this over here is the number of deaths per 1,000 person years, and you can clearly see that the control group had more deaths compared to the screening group. This is an interesting graph looking at lung cancer incidence, and the blue is the screening group, and you can see that the incidence is actually initially higher in the screening group, and that's because subclinical cancers were detected in the lung cancer screening. The patients underwent CT at 0, 1, 3, and then 5.5 years. And you can see there is a wide gap between the incidence of lung cancers between the two groups here. But towards 8 to 10 years, the incidence starts sort of plateauing and become equivalent to each other. So um, screening performed till 5.5 years sort of performs well till 7 to 8 years, and after that the effect wears off. Overall, lung cancer mortality decreased significantly in the screening group, as low as 26% decrease in men and as much as 40% decrease in women. So that was a fantastic positive finding. Overall, in terms of numbers, there were 7 fewer deaths per 1,000 men screened. And importantly, most of the screen detected cancers were stage 1 cancers, so they could be operated upfront without needing further treatment. Obviously, women smokers tended to have a slightly higher benefit of screening, and this has been seen over multiple prior studies as well. The all-cause mortality in this study was identical in the two groups, but that was because it was not powered to detect the same. We needed a much larger study population to really be able to detect changes in all-cause mortality, which, just to remind you, was lower in the screening group in the larger US study. So what do we conclude? A couple of important things compared to the US National Lung Cancer Screening Trial, which was based on diameter based nodule management. This volume based nodule management was much more efficient. So it found only 2.1% positive tests versus 24% in the American trial. The positive predictive value was much higher at 43.5% versus 3.8% in the American trial. Also, this is a very interesting and important thing to focus on. Overall, out of the 1,700 patients who died, only 370 ultimately died of lung cancer across both the screening and the control groups. Almost an equal number died of cardiovascular disease. 600 patients actually died of other cancers, and 85 patients died of respiratory disease. So just detecting lung cancer is obviously not going to be enough to save many of these patients. So what can we conclude? Lung cancer screening definitely does work. There's no doubt about it. Two large randomized trials have now proven it. A 2-year interval is probably safe for screening, so we could think of extending the 1-year interval. Although right now the USPSTF guidelines have not really discussed this. Volumetric analysis is probably better than diameter analysis, and this will decrease the positive screens and false positive rates substantially. So when we started discussing about screening, we needed a test which is reliable and valid, and clearly low-dose CT is reliable and valid. It should lead to a true improvement in survival, and now we are sure about that. And the cost-benefit ratio should make sense, and that is something each country has to decide on its own. Hopefully, India will sort of try to figure this out as well. But cost-benefit ratio is something for a national screening program. For an individual who can afford screening, clearly there is a benefit if you can afford screening in terms of reduced mortality. But most importantly, focus needs to be on smoking cessation rather than just screening. And that's because, as we saw, many patients die of other cancers and of cardiopulmonary diseases rather than lung cancer. So I think the screening CT is actually a huge opportunity for the radiologist to not just save lives, but also counsel the patient about smoking cessation, particularly if the patient has a positive finding on CT. That's probably just the right time to strike when the iron is hot and talk to the patient about stopping smoking, and that probably will go a much longer way in reducing mortality. I'm going to end with this slide, and just to share this photo of the Tulip Festival in Skagit Valley, Seattle. Pretty much similar to what we are all familiar with, the tulips from Amsterdam and Holland. I thought this would be a good photo to share to end this because the tulip season is now around in March. Hope you have a good day and thanks a lot for listening to my talk.